our session today. We're going to allow a couple more people to come on in and join us, but we're going to go right ahead and get started. My name is Danielle Davis, and I will be coordinating things on the back end of the event. So if you have any questions during the event, feel free to place them in the chat box or in the Q&A box, and I will be monitoring the chat box as well as the Q&A box, and we'll get to your questions at the end of the presentation. So for those that are new to the Michigan Alzheimer's Disease Research Center, we're a center here in Ann Arbor in a collaboration between U of M, Wayne State, and Michigan State University. We offer a variety of dementia-related research studies, and if you're interested in learning more about our wellness programs for caregivers, Lewy body dementia support groups, or if you want to get involved with research, then feel free to visit our website or our social media outlet, or you can reach out to me and I can help point you in the right direction. So now it gives me great pleasure to introduce our speaker for today. But before I do that, Bruno, could you go to the next slide for me?
Sure.
Thank you.
Sorry, hit the wrong button. There we go.
Okay, there we go. So I just want to remind everyone about our upcoming events and just let you know that there are 2 more presentations that we're going to have for this year to close out the year. You're welcome to register, and you can find out more about our about these presentations on our website as well. Next slide, please. Just so everyone knows, the presentation is being recorded today. There will be an evaluation that I will place the link for in our chat box. So if you can please complete the evaluation at the end of the presentation. Your feedback is greatly appreciated. And again, questions will be held at the end of the presentation. All right, so as I was stating, Dr. Bruno Giordani is a professor in psychiatry, neurology, psychology, and the School of Nursing at the University of Michigan. He's the Associate Director of the Michigan Alzheimer's Disease Research Center. An active researcher and publisher, Dr. Giordani is currently involved in a number of federally and foundation-funded projects involving cognitive and behavioral consequences of medical illness, including cross-cultural studies in Africa and Asia, and national and international clinical trials. We're honored to have Dr. Giordani here today with us. Go ahead, Bruno, take it away.
Thank you. Sorry, I'm having a little trouble on the flipping of the slides. Usually I'm okay at that. So folks, here's my first disclosure of financial relationships, just to get it out there. I don't have any with anybody, but my kids owe me a ton of money. Also, before I do anything, usually I like to thank the audience, one for coming, but also one for really being part of this process. So for taking part in our research, for contributing money to the Alzheimer's Center, to the Alzheimer's Association, or wherever, but just being part of the deal. And also for being a voice for us researchers with Congress. Congress has once again earmarked more dollars for Alzheimer's research, which is really critical and mainly due to the voice of the public and getting the message out. So I thank everybody for that. So what we're going to talk about today is the information from the Alzheimer's International Conference. I do a lot of meetings and things around that are sort of talking about the basics of Alzheimer's and things, but because we don't have a longer time today and there may be questions and things, I thought we'd really specifically deal with what happens around the Alzheimer's Association International Conference. This is a large conference that occurs every year, that is funded by the Alzheimer's Association and also funded by the money it costs me to go, which is not cheap, but anyway, is funded by the Alzheimer's Association and is really unique. It comes from the Alzheimer's Association's understanding that, first of all, a long time ago, there was hardly any money for Alzheimer's research in the government. It was about $500 million. And that compares to $3, $8, $10 billion for other diseases like heart disease, cancer, and HIV and things. So there was a real push towards, if we can't get money, let's at least get researchers together. And there were a number of different groups that got together with backing from Alzheimer's Association. And then the idea came way back, and I don't know what, I can't remember when I started going to them, but I went to the first one, the idea that we should have this conference. It started every other year, and now it comes every year. And the idea is bring all the researchers you can think of from all different areas all together for one meeting to only talk about Alzheimer's disease and associated dementias, or cognitive aging, and all those pieces that fit within that pie. So this was a really groundbreaking thing. And now other sort of disease categories and things are beginning to follow it. But for many, many years, it was only the Alzheimer's. Other ones were association meetings, but this was one that's sort of funded by the association, but really separate in many ways. So this year, 2 years ago, it was supposed to be in Amsterdam, and I was ready to go with the ticket and everything. And it was canceled because of COVID. And this year they were going to try Amsterdam again, and they tried Amsterdam for a pretty long time, and then Delta appeared, and that killed that, the Delta variant. So this year was a new approach, which was sort of a hybrid approach. So there really were 11,000 attendees around the world, and this is up maybe 40% higher than usual, which was exciting. But there were only 1,200 people in attendance. So there were still 3,000 presentations, but that Z down there kind of fits every once in a while, because if I was the only person in the room, it was a little bit less boring, a little bit more boring. So there wasn't the same chance to talk to people. There still was that chance, but at meetings, it's that unique ability to talk with somebody. So one other thing that always comes out at the time of the Alzheimer's International Conference, so it can be a discussion point and things like that, is always the Alzheimer's Association annual facts and figures, which is sort of pulls out their primary issues. And it's, you can get it easily off the internet. It's free to everybody. It's a sort of a big book, and it covers all the primary things. And this is sort of their single pager, talking about 1 in 3 seniors dies with Alzheimer's or another related dementia. It kills more individuals than breast cancer and prostate cancer put together. There are more than 6 million Americans living with it now, and over 11 million Americans provide unpaid care to these individuals with Alzheimer's. So that's a major issue as well, is what happens to all those Alzheimer's patients. So in 2021, because of the number of Alzheimer's patients, it cost us $355 billion to care for them. But by 2050, that cost will rise to about $1.1 trillion. Now, that estimate has gone down a little bit in the past maybe 15 years. Used to be 1.4, but I can tell you $1.1 trillion will equally break the bank, as anybody knows. So this is far too high of a cost to pay. We've got to do something about this disease. And this is the Michigan annual facts and figures that comes right out after the other one. And this gives us a little better flavor for what's going on in Michigan. This year, the number of people aged 65 and older with Alzheimer's disease is 190,000 up to 220,000 by 2025. This piece talks about the highlight issues of hospice as it increases, Medicaid, the number of dollars spent in Michigan for that, number of caregiver dollars, and the idea that we have 6 million people living with Alzheimer's disease, and this will bounce to around 13 million by 2050. So again, if we can't slow the progression of the appearance of this disease, or whatever we do, it's going to cost us an incredible amount of money aside from all the incredible caregiver time and everything else that goes into it. So one of the things, of course, since the conference was delayed and moved to Denver instead of Amsterdam, was really the idea of what's happening with COVID and the brain. So there were a couple of studies. I don't always sort of list the individual studies, but this is really kind of important. In a study of about 300 older Argentinians with COVID-19, at 3 to 6 months follow-up, 20% showed difficulties with short-term memory. 34% had more profound, of them had more profound memory impairment across different cognitive areas. So there appears to be a greater risk of cognitive impairment in individuals, especially who don't have a sense of smell following this, and if it doesn't return. In an NYU study of 310 hospitalized COVID patients, the findings really suggested that AD-related pathology may increase when they are looking at blood-based biomarkers of Alzheimer's, amyloid, and tau. It really appeared that, of course, we don't use these blood-based markers as clear indicators yet, but it really appeared that there were increases in those areas for those individuals, regardless of age, with COVID-19. So also another thing that another large study showed across the US was really the effect of the pandemic, this sort of disruption of social relationships and the kind of lockdown that occurred in senior centers and things really reduced the amount of brain stimulation for patients in nursing homes, reduced the amount of ability for contact with loved ones, and all of these things had a significant effect on individuals. Now, there also was a lot of discussion about sort of other things about the metrics of Alzheimer's. There was the idea of rise in younger onset of dementias, dementia. There's a lot of interest in early onset dementia because, of course, individuals who develop Alzheimer's disease in their very early 60s, 50s, even 40s are a very interesting group of individuals because they develop early onset Alzheimer's disease, but they develop all the neurophysiological changes that occur with Alzheimer's disease, but they haven't yet been touched by those things that many of us are touched with as we get older, such as cardiovascular disease or diabetes, kidney disease, whatever. These are pure cases. The incident rate had been, people talk about 200,000 people, but there was a real thought that we may be getting 360,000 new cases per year. There's a lot of concern now about this younger onset dementia and what does it really mean? And is it possible? In the past, we've really expected that early onset was highly related to genetic issues, but now in a vast study in the US that just directly looks at that issue of sort of early onset cases, there are clearly cases that don't appear to be genetically linked. So a lot of interest in that. Also, the global cases of dementia now are expected really to triple by 2050. And this is an interesting fact because a lot of the thought was that, like has happened in the US to some degree, as you increase education and sort of openness and more cognitive challenge and things by radios and better education, it really should decrease the overall numbers because education is one of the features. The more educated people are, the less sort of risk or the less early the onset. It's sort of a risk marker of benefit for Alzheimer's disease. But it appears that what's actually happened is, although there may have been an increase in education overall, there's been a dramatic increase in rates of smoking and obesity, high blood sugar worldwide that looks like it's going to offset those gains. So this is a really big deal. I mean, you know, the highest increases too are projected where I work in sub-Saharan Africa and in North and Middle East. So this is a real problem. I mean, my own friends in the medical centers I work in, you know, we often have, oh, would you like to go for a traditional meal or would you like to go for a Western meal? And of course, you know, I like the traditional meal because there's all these vegetables I've never tasted, but we usually end up going for the Western meal, which is frankly entirely fried. The best French fries in the entire world from all that sun, but the fish is fried, the chicken is fried, everything is fried. So again, much more work needs to be done in this area. Now, they've also noted a sharp rise in mortality rate for Alzheimer's disease in the past 20 years in the US. It actually increased 88% from 1999 to 2019. And most troubling was this sort of belt. The incident rate in the rural east, south, central parts of the country, like Kentucky, Tennessee, Mississippi, Alabama, very close to the sort of stroke belt that some people call it. Again, this appears to be related to healthcare factors, socioeconomics, and really a growing number of older individuals in those areas. But it's also sort of, it centralizes what areas we need to be most worried about in terms of caring for individuals. There was also some real concern about diversity in recruitment. I face this same issue in the work I do in Detroit, is that, you know, we really need to widen the recruitment net. I just can't get African-American men or Latinx men or even white men into a research study. And this is really important as we begin to develop brand new medications or brand new ways of defining this disorder and capturing this disorder and really doing a good assessment. We need a range of individuals. We already know that there are certain genetic differences between Black Americans and white non-Hispanic Americans. There are other things as well in terms of the genetic makeup and other things, even in terms of laterality between right and left hand and all sorts of things. So there needs to be more diversity in recruitment. And it was nice to see that that became a big deal for the Alzheimer's Association and its whole outreach pro. That basically what this is it provides sort of tailored recruitment messages for clinical trials going on, that so that it, you know, to really reach out and explain what's going on to individuals in different care areas and how to really reach individuals that we're not normally reaching. And its Outreach Pro sort of comes with a whole customized database and everything. This is a really neat thing. NIH is getting very, very invested in how to bring the messages of science to individuals and how to be inclusive with individuals. And it's really true. Now there's a competing Talk to Mind over yesterday, today, and tomorrow, all on the issues of diversity in healthcare and things, so that, and that's all NIH funded. And I think this is really important and really good to do. There were some other things on social and environmental determinants of health. A lot of interest has come because, you know, the idea that we're not quite there for a medication for Alzheimer's disease, but if we're not quite there, what else can we do? What can we do as individuals to reduce our risk of Alzheimer's? And so there was interest in this idea of resilient brains. So what, you know, there in autopsies of large numbers of individuals, especially individuals who have the classic side of Alzheimer's disease lesion in the brains, the classic plaques and tangles. The idea is if you have plaques and tangles, you have Alzheimer's disease, you will develop cognitive issues. But there appear to be people with sort of resilient brains. And, you know, I can remember when we were doing very early studies of individuals with PET scanning, where we were looking at sort of metabolic changes in the brain with with Alzheimer's disease, there would be folks that really had all the hallmarks in our mind for someone with Alzheimer's disease in terms of brain problems, and yet they appear to have no memory problems and no other cognitive problems. And so this highlights the need for sort of, can we use these ideas for therapy? Can we think about these as a way to determine who may carry neuroprotective genes and other things? So there's a lot of interest in this resilient brains, and a lot of interest in, say, super agers, people living much longer. We have a super aging study that's about to start here in at the University of Michigan in the Alzheimer's Center. So it's a very interesting area. There was also a lot of discussion too, several studies talking about appetite among patients with Alzheimer's disease and other dementias. That appetite, you know, those of us who have had family members like this, we often know that people tend to lose weight. And the question is why? Part of it is, are they actually eating at dinner time? What happens if you can't recognize food? Or in my father's case, or my grandfather's case, actually not my father's, my father, you know, he could eat any Italian food you put in front of him. But my, in my grandfather's case, I remember we could not understand why he had stopped eating, and a psychiatrist came in and all sorts of people came in. And I finally got out of him the fact that his dentures were hurting. He wasn't eating for that. Decreases in exercise by not going out, decreases in sensation and things cause issues in eating. And we know that individuals who have a dementia need to continue to eat well. So there are all sorts of different ways at mealtime to sort of calm the atmosphere, increase comfort, and give choices so people will continue to eat. It's just critically important to maintain diet. Also, it was another interesting set of studies. We've done studies looking at cognitive training and things like that, but there was a recent study that came out here that was presented that talked about doing things like reading, writing letters, using playing cards, doing puzzles, actually may prolong death, even if you start that later in life. So a couple years ago at AAIC, it was sounding like, gee, if I hadn't started running marathons by the time I was 28, I was probably out of the picture. But the issue now is that they've shown even when you do these things with older individuals, they can help reduce the risk of Alzheimer's and help with cognitive status. So this was one study that collected data over 7 years and 2,000 people with an average age of 80 who didn't have dementia, but those with the highest mental activity developed dementia at about age 84, whereas those with less social contact, less cognitive aspects, less development, less activity and all, developed dementia at an earlier average age. So it was really an important finding that, yes, even among older individuals, we can actually show an effect. Now, one of the things that was interesting, though, that they did autopsies on about 695 of those people who had passed away, and there was no association between mental activity and amyloid tau markers in the brain. So there didn't appear to be, that didn't seem to be the pill that was stopping the formation of plaques and tangles, but it clearly was having a good effect so that mental activity becomes something else that should be, you know, presented to older individuals as clearly an important thing to do. Come to talks like this, always helpful. Then another thing, there was a lot of commotion and discussion about air pollution. So I just want to say that there were 3 studies about this. I'll talk about it in a minute. I'll just sort of highlight rather than going heavily into the specifics. But what we know now is we do know that improving air quality, if you improve air quality in a large population area, you can improve cognitive function and you can reduce dementia risk. Predominantly located to fine particulates in the air and pollutants from burning fuel. We know that has an effect. Air quality that's associated with better respiratory health is associated with longer life expectancy. So air pollution and increased beta amyloid production has even been found in some animal studies and now in human studies. Sorry, I hear there's a phone, but I can't find it or reach it over on my wife's desk, and we'll let it go. Now, in terms of what we're learning now about air pollution, so the 3 studies came out that really showed that if you improve air quality, it can improve brain health, just like remaining an active brain. In other words, improving air quality reduced the risk of cognitive decline and dementia. So not just sort of other things, really directly going in and changing air quality. This study demonstrated a clear improvement. Also, there was another study that looked at reducing air pollution and reducing the risk of dementia, not just cognitive decline. And another study looked at exposure to air pollutants and beta amyloid. You know, beta, I'm not talking about a lot of the foundational things about dementia here, but you know that amyloid and plaques are the 2 things that we see in the brain of individuals with Alzheimer's. And longer exposure to air pollutants was associated with higher beta amyloid levels in the blood, in blood tests. So it's a very interesting issue. Now, I'm going to talk some about clinical trials because this got a lot of press and a lot of interest. I think got a lot of press also because we're going through the COVID-19 vaccine things and whether to give people 3rd vaccine or whether to approve the previous vaccines. And at the same time, there was aducanumab or Aduhelm. I can't pronounce these right, but we'll just let it go like that. One of the things at the Alzheimer's Association International Conference was the results of an expert panel were announced in terms of the use of this brand new drug. We'll talk about that is the first drug that purports to really affect the disease. Up till this time, in all the medications we have, Aricept, galantamine, so forth, these are medications that help the symptoms. They're not medications that basically interfere with the disease process. So the disease eventually rolls on, but this is, wow, what if we could use a medication that really was an amyloid drug that really forced the immune system in the brain to get rid of amyloid? Would that help? And so this drug came out that we'll talk about, but at AAIC, there was an expert panel and their firm belief was that you should restrict this drug to those with mild cognitive impairment and mild Alzheimer's disease. You should use the highest dose to improve outcomes, and you must monitor medication safety with MRIs, with brain scans before therapy, and at several time points along the way through the staging. So this was a big issue. And we'll talk about this drug. So this drug from Biogen, basically, there were 2 studies going on. One was called Emerge, and one was called Engage. And there were identical phase 3 studies, except one started before the other one did. So patients were enrolled with mild cognitive impairment and Alzheimer's disease. All the patients got positron emission PET scans to look for amyloid in the brain. So these were clearly, even mild cognitive impairment patients had amyloid in the brain. So to confirm that this was a marker for Alzheimer's. And an additional group carried the ApoE4 gene, which we know is associated in some ways with the appearance of Alzheimer's disease. And the primary endpoint of these studies, the sort of this is what we're going to use to determine the effectiveness of it, was called the CDR sum of boxes, or SB. And that was to have been done at 18 months. And all these treatments titrated up, but you'll see that one of the things that happened there on this slide was in the low dose and the high dose, they look exactly the same, ApoE carriers and non-carriers, but in the titrated dose, those ApoE4 carriers were not getting the high drug, and the protocol was changed to give even people with ApoE the highest drug dose. But the two studies, of course, had been going for different times. So amending those protocols made a difference in how many people got in. So this is just sort of a Biogen slide explaining what happened. But what it really means is there was, both of these studies were discontinued on December 26, 2018, because, or after that, but from that basic set of data, because it looked like there were too many side effects and there wasn't much of an effect. Then number two, what happened after that is Biogen began to look at additional data they had from these studies. And they did an additional database on the rest of the people who were in the study that hadn't been included in that first expected analysis that they always do to look at the effectiveness of the study. And in this new analysis, they said, well, wait a minute, we presented this to our external advisors and the FDA to better understand what's going on. And we think that based on our new analysis of more patients who finished up, we want this drug approved. And we mainly want it approved because of the high dose. And one study got the high dose, and that was Emerge. And what they were basically finding was that in Emerge, these are complicated little slides, but if you see the placebo group here, it kept getting worse and worse on this physician's evaluation or specialist evaluation. But if you look at the high dose here, by 78 weeks, it was actually significantly below the placebo group. So they went, hey, if we had looked at high dose, or if we just look at high dose, we have an effect. And their problem is, they said that in Engage, where no differences were found between these groups, I mean, you could say that the aducanumab group almost looked like it was having more difficulties, more problems as revealed by this evaluation, but nothing was significant in there. They said that was because this study didn't happen to have enough high dose people, because everybody with an ApoE hadn't initially been given high dose. And if you look at some of their other data, you see some similar things where a high dose, basically their mini-mental state score, which is the higher score, the better, is declining slower from baseline. The high dose had about a, 3.1 decline, but the placebo group had a, 3.85 decline. But these were significant. Same thing for the ADAS-Cog, which is a cognitive evaluation, and the ADL measure, which is a Alzheimer's research used across the country as a functional status and adaptive ability. And what you see there is that it looks like the high dose is not falling, at the same rate. Now, the difficulty is if you look at the Engage study, the study that was had started earlier, so didn't have as many high dose individuals in it, they felt, you don't see any differences on these tests at all. So, I should also note that these are changed from baseline. They're not scores. So that when we're talking about a change from baseline here, we're talking about on the mini mental state score, Alzheimer's high dose patients dropped about 2.75 and placebo patients dropped about 3.5 or so. We're not talking about big changes. We're talking about changes of a point to a couple points. So again, there's a question of from a objective standpoint, is this an issue? Is there really this famous cognitive change? And again, it's in one study, not the other, and essentially driven by one of the dose levels of that study. And the other problem was the reason why the group, the expert panel came out at AAIC with its guidance was 40% of the individuals had brain swelling or bleeding with symptoms in a quarter of them. In other words, there is an MRI problem that occurs. You can see these changes in the MRIs. These episodes generally resolve, and most people could go back to continue the treatment, but there is a noticeable change here that we've seen before in other types like babenuzumab and other trials that have been used. Is there is this frankly medical problem. So all this information came to the FDA. Remember the famous, now all we hear about is the famous panel of specialists for the FDA, the doctors of the field, and how do they vote? Well, they're given specific questions, these outside panel of experts, and they're told to respond. So does study 302, the eMERGE study, if you take it separately and pretend it engaged didn't occur, so you're just looking at the study with high dose, did that provide strong enough evidence that this was an effective drug for Alzheimer's disease? And you got one person who said yes, 8 people who said no, and 2 said, I'm not voting either way because I don't understand what's going on with all these number changes and things of people. And then another question was, in light of the understanding provided in terms of the essentially exploratory analyses, because neither study finished because of the side effects. If you consider the exploratory studies along with some results of an earlier phase 2 trial, if you put all this together, doesn't this tell you that this drug works? And no one said yes, and 10 said no. And one guy still didn't understand what the heck was going on. So this drug was pretty roundly turned down by the experts. But the FDA said, well, wait a minute. I'm really kind of thinking that, okay, we don't know if it was actually the placebo group who declined faster and nothing really happened in the eMERGE group, or maybe when you unblind them by saying you're not in the study, that changes side effects, or who knows, I don't know how to do that. So what should we say? And what the FDA said was, in June 2021 was, rather than saying no, it was go back and show me some more data, especially show me some imaging data. And so they did more studies. They looked at their imaging cohorts, and there were some studies that, remember, we're looking for amyloid and tau in the brain, and we have different brain markers that allow us to image these things. And there was some thought that if you looked at the placebo group before and after the trial, you can see these look about the same. And in the control groups, you might just say that there is less tau, less highlight than pre to post. There's a decline. And eMERGE also, and as did Engage, presented some data from only some of the subjects, because they were some of the people that, again, individuals with placebo, their change from baseline with amyloids continued, whereas it was the high dose individuals showed a decline, and that was true even in both groups, both studies. So what happened is then they came back again and said, here's some more data. And it was granted accelerated approval. Remember now, accelerated approval has become a big thing in vaccine work, right? Each of the vaccines were able to get accelerated approval. The reason why they said they approved the drug was it was a serious illness without a met need. Their decision can be based on the drug's effect on a surrogate endpoint that is reasonably likely to predict cognitive change in the future, that is, amount of amyloid or tau. But we'll say we should require some sort of post-approval trial to verify that what we believe is true. So to everybody's surprise, basically, and some people said, well, this is FDA's green light and science's red light. And clearly FDA went with the green light. And we've seen discussions like that over vaccines in general and over third doses and things. There can be controversy between the scientists and the scientists in FDA who also drive public health. So Biogen posed then that, hey, with a positive study on one side and maybe a not so positive on the other one, you ought to give us approval. And they were only required, the only requirement, there were no contraindications. There's no reason not to give it to anybody. And we'll only require you basically to monitor the process of this disease over the next 9 years in terms of what happens to people taking the drug. The important point about this, which is quite interesting, was, in a sense, the FDA also changed the standard for determining benefit from a clinical trial. It said simply the drug reduced beta amyloid, even though it didn't really improve the CDR sum of boxes real endpoint, if you look at all the data or this and that. And this was a big change. And you got scientists saying the approval may divert funding from non-amyloid causes to amyloid, and never mind the side effects of the proposed dose with the 35% brain swelling and 20% microhemorrhage. So there's a lot of, and several of the scientists, as happened even with the vaccine, several of the scientists got off the panel. They removed themselves from the panel. But at AAIC, there was some other data presented that was interesting. For one thing, this drug appeared to change on the left side. Most of the change was seen in word finding problems and in construction problems. But especially these word finding problems was really interesting. And then on the other side, when looking at this drug, when looking at some of the other things, there was a noted difference in apathy, the tendency not to move around, and agitation, the tendency to move around too much. So that the belief was, there may be some things here, but again, we have to bounce back to the fact that this wasn't what you were supposed to study to make the drug sure. So it's still not clear. So there are 3 new studies, though. Rather than, one good thing about things was, rather than just saying, okay, I'll follow it for 9 years, there will be 3 new studies. The eye care and Alzheimer's disease in the US, which will be a phase 4 study that will start, looking at people, though, who are prescribed this drug in routine practice. There will also go back in the EMBARK study to look at people who were already in the study and will now continue with the positive, with the medication rather than placebo. And they promise another phase 4, another large study that will come. But at least there will be studies. And the idea behind this EMBARK study will be that they will do the imaging, they will get the imaging data, not clear who will pay for it, but they'll get the imaging data, they'll get the blood studies in all of these people across the globe who will be administered this drug, and we will know more about it. But again, there is this little point about, hey, we'll do the study ongoing and find out what's going on. That's what upset some of the scientists. It should have been decided. And as a matter of fact, aducanumab at Michigan Medicine was voted by the specialists in the hospital, did not reach the formulary, and it didn't reach it without any exceptions. So it will simply not be offered at Michigan Medicine. Michigan Medicine doctors can prescribe it, but only if it's administered somewhere else. And essentially all those other MRI scans and everything else is done when somebody figures out how to do all that. The VA also didn't add it to its formulary. So this is a very hard thing. This is potentially a good drug, but some argue it was pushed too fast to market. However, there are other things coming up along the pike. I'll try and finish up here quickly, but there was a lot of excitement around an Eli Lilly drug, the Trailblazer study with donanemab, which in 2 studies, one study already suggested that in this smaller, these are phase 2 studies, so these are smaller studies with Alzheimer's patients, and you can sort of say, well, we know what patients without drug would look like based on all these studies. So let's see what happens in just our Alzheimer's group here. But they found that people who reached the highest dose consistently really had much less amyloid accrual, and their PET scans showed tau changes. So both amyloid, which is supposed to be affected by the drug, as well as now tau changes did appear. So there was a lot of interest in both of these studies. The other study showed, again, that both amyloid went down and tau. So they showed this in 2 phase 2 studies, but none of the regular larger phase 3 studies on thousands of people have been done yet on this drug, but Lilly still plans to submit for a license application as accelerated approval pathway. So they're seeing what happened with aducanumab, and they're saying, hey, let's get us in that mix too. So still, there's a lot of interest. The Lilly drug, a lot of people were interested in. Now, there were a few other drugs. There was Cassava Sciences Synuclein, which it looks like at another protein approach in Alzheimer's disease. And it looked like in their first phase 2 study, and this was even an interim, a halfway analysis of the study, but of course, you kind of want to get this information out there and your stock kind of rises and you can do more research. It looked like in a larger study of, I believe, some 60 people, 25% of them got CSF measures. So looking at the CSF, what was going on there to see. And they felt that there was approval, even in a short time, of the amyloid and tau in the brain. However, unfortunately, right after this got out into AAIC and the drug company's price soared like crazy, some of the internets, we have good guys and bad guys out there wandering around on the internet. And there was a group of researchers who got together and said, wait a minute, we looked at this drug stuff again, and we're not so sure. And this was in the 4 days following AAIC. They published on the internet, just sort of not published papers, not scientifically documented, but they said basically, some of this data doesn't really look right, and some of it looks amazingly like data from other studies, from other companies. So the stock dropped 50% in 2 days. So again, there are, early shots, but often you need to publicize yourself to get excitement. There was another company there that shall remain nameless at this point, but they had invested a lot in the actual meeting itself. And I went to their early drug presentation, and sitting in front of me were three younger guys in suits, constantly typing on their computers and looking at, I mean, it was in, they were clearly looking at company sales and things like that for different drugs. And they started asking questions about, well, what are you going to do with this amazing sounding drug? And what is it really doing? And hey, what are you going to do? And the person who was the head of the company said, oh, we're just going to try it on everybody. Oh, we'll try Parkinson's and Huntington's. And all of a sudden, these guys started talking to themselves, and they left. And the price of that company stock plummeted as well. So, there are a lot of these things going on. But there are other reasons still to hope with all this other stuff going on. There are other amyloid potential therapies. Now we know what happened with aducanumab, and now we know the dosing to use and what needs to be attacked. So there are other therapies coming along. There's also this recognition that it may be one or two therapies, something for amyloid, something for tau, and then something for changing lifestyles. Lifestyles have finally been noted to be important. They've been totally accepted by the Alzheimer's Association, which was a little leery about the whole running and eating well and stuff process. But one of the studies, the FINGER study, which is a very large study that the Alzheimer's disease is actually funding, that's even developing a healthy life index tool that people could use to monitor lifestyle changes. So there's a lot of stuff coming down the pike. So anyway, I was told to stop 10 minutes of, and I think I did it. And I want this down as a marker. This is the first time I've ever made it, but I want to thank you all. If you have any questions for me, I know I go fast, but I absolutely swore I'd make it exactly on time this time. And now it's 2:51, so I'll stop talking.
It's okay. Thank you. Thank you. All right. So a couple of questions that we have. So is Michigan ADRC doing any research on the role of diet in cognitive decline, as well as the importance of overnight fasting?
There may be somebody. There are so many things that so many people doing research, but I'm not particularly aware of them in the ADRC, but Danielle, you can pass that question on to folks. We can see both of those things are very interesting questions. First of all, we do know, for one thing, beyond a doubt, that if you follow the diet of the stroke belt down there in the South, which I envision with Popeye's fried chicken, which is my absolute favorite food in the world, which now I can't eat anymore. But if you change your diet to a heart healthy diet, that clearly makes a difference for your whole body. There's no doubt. And if what makes a difference for your whole body reduces your risk of Alzheimer's, they're completely linked. That's why there's so much interest in cardiovascular disease and cardiovascular friendly diets, is because cardiovascular disease also is strongly. The biggest predictor of Alzheimer's is in age. But if you can essentially slow the aging process by being healthier, let's say, you appear to reduce the risk. Also, I'm sorry, I can tell you whether the fasting diet works, because my wife is doing that with me now, because she's ordered me to do that. So I'll tell you if it changes my cognition or anything in the future.
Can, excuse me, my pronunciation, but Aduhelm, I can't even say it, but okay.
That's it.
Okay, can it be used with LBD?
There haven't been studies with that, and it's looking at amyloid change, which is different from what happens in Lewy body disease. And again, this takes more time. There were a couple of drugs that, because of the concern about the importance of trying to find clear cures for Lewy body disease, LBD, there were several drugs sort of in the pipeline in that area.
Okay. You spoke to this conceptually regarding the significant findings from the drug trial, but when you look at the data from Emerge that finds number cancel naming constructual praxis, do you think these changes are clinically relevant or just statistically significant?
Oh, I don't know. No, the truth is, I mean, I looked at this data before it was presented to the FDA. I went through it with the company, with a number of other individuals and things. And look, sometimes people say, oh, it only had a 2-point, it declined, those patients declined 1 point in mini mental state, and the placebos declined 4 points. And I'm thinking, wow, on a drug like that, if you can decline only 2 points, and it seems like a significant difference on that particular task, which is not a lot of numbers. But as to whether they are significant, but whether they are truly changing or not, they are all small changes because they're changes from baseline. And you've got to consider those issues in it. But it's interesting that the cluster of changes that they do get, and these are what are called post hoc analyses. So these are analyses after the fact, not counting the endpoint. But it is interesting that they tend to cluster around verbal skills, and they tend to cluster around the two most critical behavioral concerns. And we'll hear more of that clearly from the company soon. They appear to be reducing apathy, and they appear to be at the same time reducing agitation. So again, small changes, who knows, that needs to be studied specifically.
Okay. And have you heard anything recently regarding AD being caused by infection?
Well, there's a lot of interest in that's popping up. And this gets me back to my old line of my friends who study the gut. And I can't stand the fact that they're constantly telling me that the gut directs the brain. And I've always thought that meant the fact that I can't go buy a Popeye's chicken without drooling a little bit. But the truth is that there are certain types of bacteria in the gut and even in the gums that appear in brains with Alzheimer's. So the thought is, why are they there? Is it that the blood-brain barrier breaks down and they can get in? Or is it really more associated with gut and these gut types of disease processes that may affect the brain? It's a hot topic. There was a lot of interest over the past 2 years and kind of silence this year, which I don't know whether it means, oh my gosh, we're really in the midst of studies or not. But I think that my buddies who study the gut are not leaving me alone about it. So I think, there really may be something in that. We don't know for sure. It may be one of the contributors, or after Alzheimer's begins to appear, it may be something that pushes the disease process on, sort of like COVID.
All right. Well, thank you so much. Thank you, everyone, for your
Finished on time.
Yep, for your time and attention today. We really appreciate it. I have placed the link for the evaluation in the chat box. You will also receive an email with that information in it again. So again, thank you all so much. This will be recorded and it'll be placed on our YouTube page in a couple of weeks. So be sure to check back and be able to watch the video and share it with others.
I may have some Hershey bars for those who rate it highly. I don't know. It could be.
All right. Well, I think that's
Thanks,
it for
everybody.
today. Take care. Stay safe, everyone. Goodbye.
Bye.